Mpho Sithole. Over 1 million children under the age of 15 live with HIV in South Africa, but only half of them have access to treatment. This is all according to the United Nations Programme on AIDS. Getting HIV-positive children under the age of 3 to take the life-saving drugs has been a huge challenge, and their lives are at risk. But researchers and drug companies are fighting for innovative, child-friendly ARVs that are easier on the tongue and can be mixed with milk and porridge. To speak more on this, I'm now joined by Cipla CEO Paul Miller. Paul, a very good morning to you, and thank you so much for joining us. Looking at the current numbers, the current statistics of children living with HIV in sub-Saharan Africa, what sort of depth are we looking at here?
It's a grave concern because less than half of these children are actually on treatment. And of course, if you're not on treatment, your chances of survival are greatly reduced. The tragedy of this is that every day in sub-Saharan Africa, where almost 90% of these children live, close to 300 of these children are dying daily. So this is a major catastrophe, and something has to be done about it. And every year we get an incremental 160,000 new infections for these children.
Now, just...
Yeah, and some further work needs to be done.
Just looking, Paul, at the difficulties of feeding toddlers. I mean, that in itself is a challenge when it comes to meal times, irrespective of status. But in terms of the challenges that come with ensuring that toddlers really do take ARVs, what are some of those crucial challenges here that have prompted you to come up with a new, refined way of ensuring that ARVs are consumed by toddlers?
You're 100% right. I think every mother would tell you it's a huge challenge every morning to get their child to take any medicine, let alone having to take 3 separate solutions. So in the case of a child living with HIV, they would have to take a Lopinavir as one syrup. They would then have to take a Bacavir as another one, and lamivudine as the third one. So the problem, though, with the existing Lopinavir is that it has about over 40% alcohol in it. So not a great way for the child to start their day, having a shot of alcohol. And then on top of that, it's very bitter. So typically the child will either vomit it out or won't swallow it. And also one of the biggest challenges for mothers, particularly in the rural areas where most HIV is prevalent, is it has to be stored under refrigerated conditions. So you're getting mothers taking earthen pots and putting the products inside the earthen pot, then putting mud over it and pouring cold water over it in the hope that it's preserving the product and keeping it still active. So something had to be done about removing alcohol, overcoming the cold chain challenges, making it much more palatable than it currently is. So this was one of the challenges that Cipla took on.
So, you know, we also, you speak about rural areas on one end, and then you speak about the numbers, 160,000, you say, infections on a daily basis, if I heard you correctly. But in terms of getting an understanding of what pediatric HIV is, you know, how much do we know about what it really is? Well, Paul, just to emphasize, perhaps just for you to hear what I was saying there, I just want you to give us more detail on what pediatric HIV is, especially as you speak about the high infections in rural areas.
I think it's one of those neglected diseases in HIV. It's not a high margin area of the business. And it's a horrible word to use, word business, when treating people living with HIV. And so because it's got low margins, because the numbers are small in comparison to adults, it's a fairly neglected disease. And Cipla decided that this is one area we wanted to have an impact. And so therefore, we started to look at the attention around how do we make it easier for the mother to administer. So we brought forward more recently through SAHPRA approval, an approval of a combination of Lopinavir and Ritonavir, which is now in a pellet formulation. So it doesn't have alcohol. It basically is just in a pellet. The mother can sprinkle it over the porridge in the morning or over the milk, and the child will take it a lot easier because it's not bitter in flavor. And neither does it need cold chain management. So this is an exciting evolution, and one of the things we're doing to try and turn around the number of deaths that are happening on a daily and a weekly basis. There's a very powerful study that was conducted. It's called the Living Study, where we looked at a big cohort of young children living with HIV. And what the study attempted to do is show that with the use of Lopinavir Ritonavir in a pellet formulation, as opposed to an alcohol solution, was there a difference? Less than 50% of the patients were controlled at the beginning of the study, and after 48 weeks, more than 80% of the patients were controlled, and their viruses were suppressed. That is the powerful, powerful message. In other words, one of the big challenges we got is giving a therapy that the mother can give to a child that actually the child will accept, and therefore compliance goes up and the virus gets suppressed. If the virus gets suppressed, rest assured the death rate is going to fall dramatically.
Now, with the exciting evolution, Paul, what age groups are we looking here at? And in terms of accessibility, has it been rolled out to public hospitals already?
It has, and the exciting thing is that we're looking between ages of 0 and 14. And what we've done as well is we've dropped the price dramatically. So many, many years ago, when most people were living with HIV 20 plus years ago, it was a death sentence because it cost you close on $150,000 to be treated with ARVs. At that time, Cipla made those medicines available at $1 a day. And so with it becoming available $1 a day, immediately we could start treating vast numbers of patients across Africa. And similarly, we've brought this formulation down to $1 a day. So it's a very affordable treatment. It's been sponsored and supported by the Department of Health in South Africa, and we're looking now to launch this product across South Africa. And we do believe, in partnership with the government of South Africa, this is going to make a difference, particularly for children living with HIV. The challenging area, though, is between the ages of 0 and 6 months. And here we cannot give a burden of 3 different molecules to treat those children living with HIV. So we're looking to formulate another formulation where we put all 4 molecules into one formula. And this is an exciting one. It's called Quadrimune. And we're looking to submit that now with SAHPRA. And we're hoping with an expedited approval, we'll even be able to not have now 4 different drugs and 3 different formulations to be taken, but we now will get 4 drugs in one formulation. And I think the compliance and the viral suppression will be so much greater and stronger.
And Paul, lastly, before we let you go, in terms of how you consume the product, I know that with adults who take ARVs, there's certain times that they need to take it at. And just give us more on how you consume it. Are you allowed to have it with, have the ARV and then later have tea or something hot? Does it really absorb in your system correctly, having had something hot with it at the same time?
Yeah. So typically you'd want to give this first thing, at breakfast time to the child. That's when everyone's on the march in the morning. Mom's up, dad's up, the kids are getting ready for school. That's the best time. Get a healthy meal into the child. And with that healthy meal, make sure you add the HIV treatment into it. It should be a palatable format where it can just be added to the porridge or whatever it is that the child chooses to eat. There's no real concerns around what you should or shouldn't take with it. The most important thing is to get it into the stomach on a regular basis every day at the same time. And if you miss your therapy for a day or 2 or 3, resistance can start to build. And that's not what we want, because then you have to start to go to more complex regimens that are more expensive, less well tolerated. And therefore, it's absolutely critical that every day at the same time, the child takes their medicine with the support of the mother.
What are some of the side effects that come with taking this medication?
It's very well tolerated. And I don't want to go into all the clinical manifestations of the side effects, but I think if the mother does start to pick up that the child is not responding well, there's either lethargy or the energy level falling, they should definitely go back to their clinic and get some feedback on it. Obviously, as you initiate your therapy, you would go back on a regular basis to collect your medicines every 3 months. But as you initiate, you probably go back more regularly to really make sure the child is tolerating it well, that all the clinical markers are under control. So it has to be well managed and it has to be carefully monitored through the medical care. And I think if there's any doubt, the mother should not hesitate to contact the prescriber that gave the child the medicine.
Thank you so much. Let's leave it there. Thank you for your time. Cipla CEO Paul Miller there just speaking to us about a new innovation, exciting developments around pediatric HIV, a child-friendly ARV that's easier on the tongue between the ages of 0 and 14 years. It can be consumed with porridge and milk, just making this easier for the young ARV consumer.